Hello, and thank you for joining us for our debate on the ethics of treatment approaches, focusing on punishment as an intervention. My name is Annie, and I will be the moderator for the duration of this debate. The stater for both sides of our debate will be Ellen. The pro-punishment side will be taken by Brandon, and the con-punishment side will be taken by Diana. Each side will discuss a topic relevant to punishment. First topic will be efficacy, then legal, competency, and acceptability. The use of punishment in the field of behavioral science can be dated all the way back to B.F. Skinner with his work on animal behavior. In the 1950s and 60s, behavioral principles began to be used on humans, which led to the use of all kinds of punishers. When applied behavior analysis began, the concept of a functional behavior assessment had not yet been developed. Therefore, many early intervention plans used several forms of punishment consequences that were physical or painful in nature. Some included unconditioned punishers and other aversive stimuli such as soap in the mouth, shame, and contingent electric shock. Some other examples can be seen in the following figure. By the 1970s, the United States became aware of the conditions in many institutional settings involving the use of punishment and undignified treatment and began setting some standards for ethical treatment. By the 1980s, the use of painful or uncomfortable punishment procedures experienced a wave of ridicule. Many disability advocacy groups began to make a stand for ethical treatment. The government began to follow in support. A movement for positive behavior support plans began, and by the late 1990s, the Behavior Analyst Certification Board began to set an ethical code for behavior analysts. Even with standards and laws in place, inconsistencies in what is defined as punishment and what is included in each intervention has led to the disparities between states' legal view of punishment. 1975, children with disabilities had no legal right to attend public school in the U.S. In 1973, Congress enacted Section 504 of the Rehabilitation Act, which prohibited discrimination against individuals with disabilities. There was finally federal funding by 1975 for free appropriate public education, and in 1990, Congress renamed these statutes to create the Individuals with Disabilities Education Act. IDEA was reauthorized and amended in 1997 to include that a child's IEP must have strategies, including positive behavioral interventions, strategies, and supports to address problematic behavior, and again in 2004 to include that in the case of a child whose behavior impedes learning, the child's IEP team must consider the use of positive behavioral interventions and supports, and other strategies to address that behavior. It also added that an FBA and a BIP be used. Currently, all states' definitions of punishment differ, which brings about controversy and confusion among families and professionals.
As behavior analysts, we abide by the Behavior Analyst Certification Board Professional and Ethical Compliance Code. One such code states that our clients have the right to effective treatment. This poses the question, is the use of punishment providing effective treatment, or is the omission of punishment as an option denying effective treatment? Analysts who state that the use of punishment is ethical maintain that in cases when all reinforcement-only strategies have proven unsuccessful in reducing problem behavior to acceptable levels, punishment has shown to be effective when implemented competently. Those who state that punishment is always unethical are not concerned with the research on punishment efficacy, but rather the ethical core principle of care and compassion.
Thank you, Ellen. Studies that use punishment techniques have been proven to be effective through solid data. Gregory P. Hanley conducted a multiple baseline study to test the effects of using NCR, FCT, and FCT and punishment combined as interventions for aggressive behavior in 2 children. Both children engaged in the lowest rate of problem behavior given the FCT and punishment condition. Although FCT, or function-based, was effective, it resulted in intermittent rates of problem behavior with both children. In the punishment and FCT condition, the low rates of sustained and maintained. These results are consistent with previous research, and that function-based interventions can be effective, but punishment can be combined with these techniques to produce faster and greater results in behavior reduction. Et al. Used restraint fading to reduce self-injurious behaviors. They coupled this with the punishment procedure contingent exercise, where the researcher asked the children to touch their toes repeatedly upon SIB. In this intervention, all SIB behaviors reduced to nearly 0. With the withdrawal of this exercise resulted in an increase of other SIB, and when reintroduced, dropped back to 0. In the last 28 sessions of the experiment, there were 0 instances of SIB. Not using restraints at all would have resulted in tissue damage, and not using the contingent exercise punishment procedure would have most likely resulted in maintained other SIB behaviors.
You stated no data collected on the amount of reinforcement delivered per condition. There are studies of punishment used that include shock, noise, blasts of air. This cannot possibly be ethical treatment. Dense reinforcement could produce better effects than a mild punisher. The BACB Code of Ethics also states that we have to take the effects of interventions into consideration when deciding upon them. The use of punishment has effects such as emotional reactions, aggression, escape or avoidance, and when we are modeling the use of punishment as acceptable. Lerman and Vorderman, 2002, mentioned that this is unnecessary since we have functional analysis and plenty of research on establishing operations, extinction, and reinforcement efficacy.
Of course, we must look at the side effects of all our interventions. However, for cases that require rapid reduction of harmful behaviors, such as aggression and self-injurious behavior, the benefits and effects of treatment greatly outweigh the side effects. Of course, we use less instructive methods first, but it is unethical to withhold more effective treatment, especially in painful and harmful behavior situations. Gregory P. Hanley et al. Provides suggestions for reducing aversiveness, differential reinforcement of alternative behavior, increasing reinforcement density, make the punishment schedule contingent, signaled, and predictable. Efficacy of all behavior interventions depends on history, use of extinction, type and amount, and the schedule of the consequence. Behavior must be reduced to acceptable levels, especially when harmful. As Mattson and Kasdan pointed out, the main objective of punishment is rapid reduction of problem behavior. It is not meant to be a sustainable intervention, as punishment procedures are planned to be faded out just as any other intrusive behavior intervention. The aversive stimuli you listed were used as punishers over a decade ago. Unfortunately, there are more studies in that time using unconditioned punishers than the current. Less intrusive punishers used today. In fact, I bet you use some tactics that are actually punishers. Response blocking, guided compliance, and protective equipment for SI behaviors, to name a few.
It seems to me there's very little research done on these less intrusive punishers. If we deemed punishment itself as ethical, then who is in control and who moderates researchers or clinicians from using any punisher they decide is more effective?
It is clear that both sides feel passionately about the core ethical principles present in this debate. Specifically, with the topic of efficacy, the pro-punishment side argues that punishment is a highly effective strategy when used appropriately, and the anti-punishment side argues that there's little research to support this.
Thank you for your thoughts on both sides of efficacy. Next, we will discuss legal issues as they pertain to punishment as an intervention. The long history of using aversive stimuli as the predominant method of punishment has continuing implications on the selection of punishment as a treatment option currently. The legal debate of whether punishment should be used as a treatment option is clouded by issues such as government and school officials' disagreements on when and if punishment should be used, and even further by the complication of professional codes within these environments. In addition to schools, centers, day programs, and clinics, all face the issue of legal codes that guide decision-making in regards to the use of punishment procedures. Let's consider some of the core legal issues surrounding punishment procedures. Brandon, you may present your points.
The type of punishment often described in case law and allowing such procedures involves positive punishment, specifically the use of aversives. These aversives can range anywhere from the use of electroshock therapy to the use of a timeout room to verbal reprimands. In a school environment, the former, in addition to restraint procedures, are some of the more likely procedures to be seen. The Individuals with Disabilities Act, and specifically a student's Individualized Education Program, or IEP for short, requires the school to meet the child's individual needs. There are many cases where the use of non-positive interventions, or at least the option thereof, should be discussed. The state cannot ban punishment, as it has in some districts, because doing so would potentially fail to address all of the student's needs. In these legal decisions, the courts have made glaring mistakes in their understanding of not only what constitutes punishment and its proper use, but even the science of applied behavior analysis as a whole. The shift from individualized treatment to systems of treatment such as positive behavior support in its current form may meet the needs of a number of students, but are banning or limiting the use of an intervention because of its potential ill effects on a majority of a population fails to address the more severe behaviors of a select group. Often interventions that rely on punishment are a necessity in the treatment of these individuals, and their rights are being violated by states outright banning the use of the punishment in some cases, as we have seen in the controversy surrounding the regulations that New York issued restricting their use.
Less restrictive alternatives should be sought out before the use of punishment. In addressing the needs of the student's IEP, there can be often procedures such as reinforcement that focus on positive interventions that have similar efficacy to punishment procedures. Positive behavior interventions and support, or what is often shortened as PBIS, should be a first choice alternative to punishment procedures. PBIS and similar less restrictive procedures have provided the courts with an option that shows that there is a clear treatment option that is evidence-based and allows the individual being treated to not have to suffer through the discomfort or pain often associated with aversives used in the punishment procedures. In addition, inconsistencies in what is defined as punishment and what is included in each intervention has led to widespread differences between states with respect to their legal view on punishment. Each school district can implement the procedures they deem necessary based on their state's legal code and federal legal code. However, this is further complicated in the debate between whether the use of punishment is ethical because of the difference in legal codes from state to state and then from state to federal level.
While positive behavior support can be both an effective individual and group treatment option, it is not an all-in-one answer. Many lawmakers have pushed for an exclusionary approach, only allowing systems of treatment that don't allow the use of punishment procedures, specifically those involving aversives. PBIS itself was initially intended for individual use, and there was even disagreement over what constituted a positive intervention. For example, some behavior analysts in the early history of the PBS system had disagreements on whether the differential reinforcement of other behavior, or DRO, or differential reinforcement of alternative behaviors, or DRA, procedures were punishment procedures or not. There's been a lot of controversy within this system as it has been developed from an individualized treatment option to a group treatment option, often aimed at improving behavior of school as a whole. Less restrictive alternatives should always be used first, but the argument of one particular system and the legal debate should not win the legal argument. It should also be noted that IDEA does not allow a state to restrict a certain behavioral intervention. Our BACB compliance code as behavior analyst, it states in code 4.08 considerations regarding punishment procedures the following: reinforcement before punishment, but punishment remains an option. The compliance code isn't a legal document, but it is a case where there is indicated, at least sometimes, the use of punishment. While not arguing the efficacy of punishment, there is evidence in the BACB compliance code and IDEA for the use of non-positive interventions, including the use of punishment.
With IDEA, there has existed in the past several cases where the school district has failed to properly implement punishment procedures or has used aversives instead of less restrictive alternatives, therefore resulting in an adverse view on the use of punishment as a whole. This has led to the use of PBIS systems and even a ban on non-positive interventions in some states, as we both have mentioned. Addendums to IDEA have also restated that they believe that through a proactive approach to most behavior and through the use of positive behavior interventions and supports that there will be positive results with a reduction in the problem behavior and an increase in the educational results of the child. Lastly, as mentioned before, there is still great separation between almost every state between what constitutes aversive treatment. There needs to be a serious investigation from federal government into whether or not each state is following IDEA as it is supposed to be followed. States are more restrictive. If anything, more states are more restrictive than need be, which is telling and evidence that punishment procedures with a focus on aversive should be avoided.
There is still much to be covered by the government and school districts in order to settle this legal disagreement. Although IDEA and the BACB compliance code help guide professionals in the development and implementation of behavior plans, both sides seem to agree that tighter and more explicit laws or guidelines are needed.
This seems like the appropriate time to discuss who can ethically deliver punishment. Diana, you just posed the question of who is to control and moderate researchers or clinicians from using any punisher they decide is more effective. Brandon, what are your thoughts regarding the ethical implementation of punishment by staff, therapists, or caregivers?
Start, Annie. I'd like to look at the research on interventions that involve punishment currently with other modalities. No punishment procedure should ever be implemented by an untrained hand. Hanley et al., as stated previously, conducted an experiment that utilized functional communication training with punishment, enforcement, and functional communication training on its own. During the study, the participants were provided choices for their intervention. Furthermore, caregivers were provided with a list of possible punishers that they thought would be most effective in reducing maladaptive behaviors, and that the caregivers and therapists could implement safely and consistently. Provided on the punishment techniques for the therapist and caregivers. The key individuals involved in the participants' lives were selected to deliver the punishment. This is important to consider, as it was not deemed appropriate for just anyone to deliver the punishment except those who will be able to consistently and safely execute the program. Matson and Kasdan, 1981, discuss ethical treatment as utilizing trained staff and the correct amount of staff for any punishment procedure. Execute the contingencies and demonstrate proficiency in applying techniques. They meet a requirement of proficiency to be involved in the application of punishment procedures. A trained supervisor or BCBA must train the staff who will be implementing the intervention for the full duration. Results show that the effective implementation results in lasting behavior change and reduction in problem behavior.
Training is of the utmost importance when considering utilizing punishment-based procedures. If staff are inadequately trained, failure in the plan is likely. Supervisors must train staff and parents on proper techniques, which can be time-consuming and lengthy. It is imperative for appropriate application of the program though maintaining consistent training and supervision is required, which may not always be feasible. It can be extremely difficult to keep trained staff on at all times during intervention involving punishment, which can skew the results and deem the treatment unethical. Untrained staff can never ethically be considered to deliver an intervention, punishment, or otherwise. When a staff caregiver ceases to be engaged in the intervention, new staff must be trained on the intervention. Interruptions in treatment are not effective or consistent. This brings me back to dense reinforcement. Implementing positive reinforcement requires less training and maintenance than a punishment-based intervention. It is direct and focused on the increase of prosocial behaviors.
I'd like to draw your attention to Figure 2 from Hanley et al., provided by Brandon.
Thank you. This figure provides clear evidence for the stability of the FCT intervention with punishment. The researchers who carried out this study systematically engaged in the treatment conditions. They were trained to do so effectively and safely. The caregivers were also trained to implement the punishment procedures in the same manner. The results show that this method was effective in reducing aggressive episodes under treatment conditions. Researchers and practitioners should first and foremost have the goal of keeping their clients safe. That being said, the use and punishment on SIB may be necessary to prevent further damage.
I can recall the study by Kang, Abbott, and Wilder, which examined the use of restraints as punishment for self-injurious behavior. The practitioners were trained in the mechanisms for punishment and effectively applied the restraints. However, this study found that upon application of the restraints, other topographies of SIB developed. Even if the staff were trained in the effective implementation, there may be serious ramifications and consequences that ensue from engaging in punishment procedures. Furthermore, following the increase in other SIB enacted by the participant, an environmental enrichment procedure was implemented, which still had little effect on the other SIB the participant engaged in. These consequences must be evaluated so that no harm is done to the client and they are treated with care and compassion, core principles of behavior analysis.
Points were made regarding the effective training of practitioners implementing punishment procedures. Therapists and caregivers must be effectively trained on the implementation of the program and be held accountable in the precise delivery of the punishment. Complete and continuing training is extremely important. For the treatment to be considered ethical by ABA standards, only competent practitioners and caregivers may deliver the punishment. On the other hand, even when competent therapists, caregivers, etc., deliver punishment procedures, there's a likelihood that the program will elicit different topographies of SIBs or problem behaviors that might not be avoidable. Additionally, punishment should always be implemented in addition to other programs that utilize positive reinforcement, which generally take less time to train on and implement.
Thank you. There are 3 compliance codes addressing the acceptability for behavior change. Adherence and examination of these codes may be particularly salient when punishment is being considered as part of a treatment package. Section 2.05, titled Rights and Prerogatives of Clients. Section 4.02, titled Involving Clients in Planning and Consent. And 4.08, Considerations of the Use of Punishment Procedures, are the guiding codes when analysts are considering and designing behavior change programs. Associated with the compliance codes are the guiding principles of benefiting others, being just, and according dignity. The questions at hand are who should give consent when punishment is part of the plan, and how is acceptable punishment decided. Diana will now present her points, then Brandon will follow with his.
The history of the use of punishment is dark and sordid. In a paper by Kasdan and Johnston, 1981, punishment procedures used between 1968 and 1979. While most of these techniques are not currently in use, the fact remains that at one point in time, these forms of punishment were allowed to be researched and published. Some of the aversive consequences were studied even after the Sunland Miami scandal brought us the start of the ethics code we use today. This begs the question, who is in charge of determining what is socially valid forms of punishment and what is not? In a mass survey conducted by Reed and Levitt, 2008, behavior analysts were asked their views on the use of efficacy of punishment. The results were varied across the board, indicating there may not be consensus even amongst professionals. Another study conducted by Kelly and Holmes, 2014, surveyed the acceptability of punishment between 2 groups of teachers, those without ABA training and those with. Teachers without ABA training were for the use of punishment for bad behavior, Whereas the group of ABA-trained teachers were for the use of reinforcement procedures as a correction to bad behavior. This study highlights the penchant to use punishment as a controlling mechanism to behavior, even more so without behavior training, which could lead to a wider acceptability of the use of punishment, even when not appropriate. If professionals cannot agree on the use of punishment, and studies indicate those without training are even more likely to agree to use of punitive procedures, then how can we say what is truly an acceptable form of punishment?
The BACB's stance on the use of punishment in section 4.08 outlines that reinforcement systems must be applied first and determined not to work before analysts consider the use of punishment or if it is deemed necessary due to the severity and dangerousness of the behavior. It is through this lens that all behavior change decisions must be viewed. In a study by Salvi et al. 2004, examined the use of punishment to prevent severe headbanging in preschool children. This is a case where rapid decrease of the problem behavior could save permanent damage or prevent death. As part of their research, they discussed the acceptability of their choice procedure. It may be hard for day-to-day, non-health or life-threatening behaviors to be prescribed punishment procedures based on a consensus of acceptability. It is not a difficult choice, however, to use punishment procedures when rapid decrease of a behavior will save a child from permanent damage or death.
Barring life-saving circumstances, the question of who determines social acceptability of punishment is still an area of contention. Furthermore, who should be allowed to consent to these punitive measures is also up for debate. The discussion of who a behavior analyst client is and who is the best interest they are working for are also up for debate. In an article by Slocum et al. 2014, they note that the key decision makers are not always influenced by the increase or decrease of a certain behavior. Other social variables play a role in their decision about accepting evidence-based practices. The authors note that Carnan, 1992, Plosgrove, 2003, discussed other factors such as anecdotes, appeals to philosophy, and even marketing having more sway over treatment decisions than evidence of success. This brings us back to the issue of who our clients are and if our primary clients are at the whims of other decision makers who are influenced by stories or philosophies rather than research-based practices, how can we say that anyone other than the primary client given consent for punishment procedures? Beyond the dilemma of secondary clients making choices for our primary clients that may not be based in evidence or guiding principles as noted by Wolf in 1978, behavior analytic practice can only be termed successful if we use procedures that are judged appropriate by our clients, that are valued by our clients. After all, we must be just and treat others how we would like to be treated.
As will other forms of treatment, children are not able to make their decisions, leaving the choices up to their guardians. Client is defined as the individual who is the focus of behavior change. Other individuals who are critical to the behavior change process. Bayer et al. 1968, Hewitt et al. 2005, as well as outside individuals or group who may have a stake in the target behavior or improved outcomes. Our definition of a client, based on the mentioned authors and our compliance codes, which includes those with a stake in the target behavior, are expressly there to ensure those who have limited ability to make their own decisions have access to the most effective treatment and to identify who ethically can make choices for behavior change programs, including punishment procedures. Beyond this definition is the golden rule or be just principle, along with evidence-based practices that ultimately led behavior analysts in the direction of appropriate, ethical, and effective treatments. Referring back to the Slocum et al. Article, they also discuss how evidence-based practices should be a guiding light for analysts in discussing and deciding treatment. Data is the initiation for the conversation about the use and punishment, and from there is a team decision. If the primary client can make their own decision, then all the better. However, if the primary client cannot make their own decision, such as when there is a conserved, dependent adult or child involved, it is on the owner of the behavior analyst to look at all the evidence and make the appropriate recommendations. Follow all the guidelines and ethical codes before, during, and after using punishment-based treatment.
In summary, an argument was made for the possibility that there is still disagreement within the profession on the acceptable use of punishment, as well as some evidence that shows that those in society working with vulnerable populations can be quick to use punishment for bad behavior. The rebuttal to this discussion centered around the code, which mandate behaviorists use positive reinforcement systems first, before exploring punitive practices. The case of a severe problem behavior which can result in permanent injury or death as an instance when this would be socially valid and appropriate. In a second round of discussions, the issue of consent was addressed. Some research indicates that key decision makers may not use evidence and data to make their decision on treatment. The position that only the primary client should make decisions regarding punishment procedures was taken. This was rebuffed by bringing the discussion back around to ABA Ethical Code's definition of the client, as well as the behavior analyst's role in using evidence-based practices. As it stands, the ethical argument of pro versus anti-punishment continues to be a prevalent one in the field of ABA. Through this discussion, and countless more in the future, professionals and service providers seek to benefit the lives impacted by this decision. We invite you to think critically yourselves on this topic as we conclude this debate. Thank you.
Thank you for joining us, and we hope that you learned a lot